So I just want to introduce myself. My name is Christina Johnston. Can everybody hear me, by the way? I don't have to shout or anything. Everybody can hear. So I'm a general neurologist. I work here in Holland. I've been working in Holland now for 3.5 years. So they approached the neurology team and asked if somebody would give a talk, and I thought a stroke topic would be a really informative informational talk to give, because stroke is really common. It's what I get calls about from the emergency room all the time, and I wanted to create some awareness so that just to give you sort of an insight about what a stroke is, what causes a stroke, and how to recognize stroke and what to do about it. So I just have a whole bunch of slides. I do have time at the end for questions. If you have questions in the midst, please raise your hand. I'm not opposed to answering questions as we go, so feel free. Okay, I'll just keep my eye out for hands. So disclosures, none. I don't work for any pharmaceutical company or drug company, or I'm not getting paid to do this lecture for any other reason except for just to educate the community. So I wanted to begin with sort of some stroke myths, because sometimes I think that stroke is misunderstood, or it's inaccurately described by the lay community. So stroke, one of the myths is that stroke affects the heart. Stroke only happens in the elderly. That pain is the #1 symptom of stroke. Stroke can be slept off and you can wake up without symptoms. That emergent care isn't always necessary, and that strokes are not preventable. Immediately after that, I want to address these directly, and then we'll continue going through the talk to address all of these myths and sort of hopefully correct any misunderstandings about stroke. So stroke is actually what we call a brain attack. I put that in quotations because everyone knows what a heart attack is, where there's a problem with blood flow to the heart, which obviously is manifested with chest pain, and everyone recognizes chest pain because it hurts. A brain attack or a stroke is something completely different, although it's not painful. It can occur at any age, but frequently the elderly population is most affected due to multiple factors. But it can even happen in children. In fact, it can happen in utero, so babies before they're born can have stroke. So it's not exclusively for the older population. It's almost never painful. In fact, when I hear that it's painful, it makes me question whether something else is going on, although there are certain forms of stroke that can be painful at times. Sleep is certainly not recommended. If you think you're having a stroke, you should not go to bed. You should not go home and take a nap. You should not give it an hour. You should not wait, because time, as you'll learn, is critically important. Emergency treatment is necessary as soon as you recognize symptoms, and that they definitely are preventable. So some stroke statistics: approximately 800,000 new victims annually in the United States. That's a very large number. Approximately every 40 seconds there's a new victim of stroke. It's actually the 5th leading cause of death in the United States, and 87% of these strokes are actually ischemic strokes, and I'll teach you what that means going forward here. Almost 80% of these are preventable based on the risk factors for stroke, which we will cover. It's absolutely the #1 cause of disability in the United States. It's very highly expensive. Approximately, the statistics I got from the National Institutes of Health was that it's approximately $34 billion a year spent on caring for stroke victims. So very, very costly. So as I said, what is a stroke? A stroke is a brain attack where basically the arterial supply of oxygenated blood to the brain is interrupted by some mechanism, whether that be blockage of an artery or a hemorrhage, so bleeding in the brain. This actually is very critically damaging to neurons. Brain cells are extremely sensitive to oxygen, and lack of oxygen can be very quickly damaging, sometimes permanently if left untreated for too long. The symptoms of stroke are variable, and of course it depends on what part of the brain is affected. There are many arteries that travel through the brain, and these get smaller and smaller and go to more critical locations within the brain. So it sort of depends on which artery is affected, which will determine what symptoms occur for the patient. This is just sort of an illustration of this arterial supply. So this is sort of the middle cerebral artery, which comes off the carotid artery. Everyone's heard of the carotid artery. It enters the brain and it travels laterally. And this is sort of an enlarged illustration of some atherosclerosis or cholesterol plaque that's building up in the wall of the artery. So you can see that this becomes sort of narrowed here. And then right within that, there is a blood clot. So something has, there's already some blockage, sort of clogging of the pipe, so to speak. And then we see that there's a clot that got stuck in that narrowed part of the vessel. So this patient probably developed severe stroke symptoms because of the location of this artery that's blocked. So the two main categories of stroke are thrombohemorrhagic stroke or bleeding within the brain, and ischemic strokes, which are approximately 80% of strokes. These ischemic strokes can be broken down into two other categories. So embolic stroke, which is when a blood clot leaves some other region of the body and travels up and gets stuck in the brain. There's some seats in the front here. Okay. And thrombotic stroke, which is when a blood vessel which is already blocked by some cholesterol, when that cholesterol ruptures and blocks the artery. These are some illustrations of what a stroke would look like. So this would be an ischemic stroke where there's blockage of blood flow. So you can see here that this artery is blocked, and then this whole grayed out area is the region of the brain that receives blood supply from that artery. So that part of the brain is now in danger of losing function because it's not getting blood supply, and it happens within minutes. Hemorrhagic stroke is over on in this slide here. Now this is bleeding on the brain. So this artery has somehow ruptured, and this blood has entered the neurons, and blood is extremely toxic to brain cells. So I have a video here that I want to show you. It's about 1 minute. It's sort of a general synopsis. I found it on YouTube, and I actually thought it was an excellent video, and there's no way I can put this together myself. I'm not technologically inclined. So I just want to show it to you, and then I'm going to sort of expand upon that in this lecture. But I think it's really excellently done, so it's short. So.
A stroke may occur when there is an insufficient supply of blood to a brain region, or when damage to the vasculature in a specific brain region causes bleeding into the nervous tissue. In general, there are 3 types of strokes that occur. They are classified based on the type of vascular defect that causes them. Cerebral hemorrhaging occurs when a vessel bursts, causing bleeding in a region of the cerebral cortex. An embolic stroke occurs when small clots that formed on other parts of the circulatory system occlude cerebral arteries and cut off the blood supply to a part of the cerebral cortex. An ischemic stroke occurs when a narrowing or blockage of cerebral vasculature results in oxygen deprivation in a specific part of the cerebral cortex. The specific functional deficits observed in someone who has suffered a stroke can be correlated with the functions of the damaged cortical region. In a healthy brain, the nerve impulses from the cerebral cortex travel through the brain and cross over to the opposite contralateral side of the body. When a stroke occurs, damage to the cortex is usually unilateral, since information to and from the cortex crosses over the midline. The effects of a stroke on the left side of the brain occur on the right side of the body. A person who has suffered a stroke may experience paralysis that may involve the face, weakness or paralysis of limbs, often limited to one side of the body, loss of sensation that parallels paralysis, difficulty with speech, double vision, loss of vision, dizziness or vomiting, severe headache, loss of consciousness.
Okay, so recognizing the signs of stroke. Symptoms are usually very sudden in onset, within seconds to minutes, and they usually will continue to rapidly worsen. So a tingling that comes and disappears within 5-10 seconds and is gone is not what I'm referring to. I'm referring to symptoms that start in one portion of the body, for example, the face. Numbness, tingling, droopiness, heaviness that starts to seem like it's getting worse and worse and spreading to other parts of the body. So there's a great acronym about this that's a great way to assess whether you're truly having stroke symptoms. So the acronym is FAST, F-A-S-T. So F stands for face. So a good way to assess if you think you're having stroke symptoms or someone you know is having stroke symptoms, have them smile. Actually have them move their face. Have them show your teeth. If you can move both sides of your face, that's a good thing. If one side is clearly drooping and not rising up or moving, that's concerning. The arms are frequently affected. When the face is involved, the arms are usually involved as well. So have the individual or yourself put your arms straight out and see if one of them is like extremely heavy and you can't raise it, or if it seems to want to fall back down. That's a very concerning symptom as well. Speech can be profoundly affected. In fact, it can be so bad that you can't speak at all, or your words can come out completely discombobulated, unclear, not making sense, incoherent. They can even just be simply slurred because the mechanics of your mouth movements aren't working properly. If any of these things are found, then time is really, really important. You need to either call 911 or you need to get to the hospital as soon as possible because time is really valuable here. Symptoms are variable, dependent, as I said, on where the location is. But generally speaking, the rule is that if it affects one side of the body, it's concerning that it's probably coming from one particular location of the brain. As that video indicated, the left side of the brain controls the right side of the body, and opposite. The right side of the brain controls the left side of the body. So if you're having symptoms that start on one side and continue to spread throughout one hemisphere of your body, that's important. Similarly, you can have symptoms of visual loss that will affect one side of the vision. If you close one eye and you can't see out of one side, and you close the other eye and you can't see out of that side of the eyes, both eyes are affected, that's concerning. That could indicate that there's problem in the visual cortex of the brain. Sensation can be affected without strength involvement. So just not having the ability to raise your arm, that's concerning. But you may be able to raise your arm but have the sensation be gone and you can't feel it. Perhaps it's tingling. Perhaps it feels like you're having burning or something of that nature that's in the face, the arm, and even the leg can be involved as well. So, but unilateral symptoms they raise a red flag to a neurologist or an emergency room physician that stroke needs to be considered. Sometimes the symptoms are headache, and in those circumstances, it makes me more concerned about possible hemorrhage. Hemorrhagic strokes do tend to be painful. Ischemic strokes almost are never painful. I will say almost never. But hemorrhagic strokes can be painful. So, in fact, they can be excruciatingly severe headaches. Sudden decrease or change in the vision is one thing, but you can also have double vision. You can have loss of vision in one eye. You can have loss of vision in both eyes. You can feel off balance. You can feel like it's difficult to walk or you're unsteady. And unresponsiveness can also be a symptom of stroke. If you have a family member who you can't wake up or didn't wake up in the morning or is more sleepy or more lethargic, that's also concerning for possible stroke. So as I said, it depends on where the stroke occurs and the degree of stroke involvement. If it's a very large stroke, it will have several of these bullet points. So, but the big thing is you need to understand and recognize so that you can get treatment as soon as possible. 3 hours up to 4 hours is about as much time as we've got to do something about it. So it's really important to get to an emergency room. So time is brain, call 911, get to an emergency room. Do not go to sleep. Don't pretend it didn't happen. Don't imagine that it's just going to disappear. If it does disappear, great. However, that's still concerning because what you could be experiencing is something called a TIA, which I'll talk about as well. So that's another warning sign of stroke. So that also needs emergent attention. So, but the sooner you get an evaluation, treatment and recovery is much, much increased in terms of your potential for that. So what is a TIA? So a TIA is a mini stroke, meaning that there's a blockage of an artery here from a blood clot or some atherosclerotic plaque, calcium or calcified plaque that's ruptured and has platelets that have kind of formed around it and have actually occluded the vessel. Now, your body has an ability to dissolve clot on its own. And there's proteins that circulate in our blood that actually disrupt clot so that we can keep blood flow to all the critical portions of our body. So we do have the capacity to some degree for tiny little clots to heal itself. And so you can have symptoms that maybe only last a few minutes, maybe up to 5-10 minutes, usually not longer than an hour. okay? And when symptoms start to improve, you can completely recover your neurological function. However, that still shouldn't be ignored, because what that tells us is that something isn't right. You've either got a problem with your blood pressure, your heart is malfunctioning, or something is leading to a greater problem, and you're at risk for having another stroke, or having a real stroke within a short time. Approximately 15% of TIAs will have a stroke within 6 months. So 15% doesn't seem like a big number, but it is. 6 months isn't a very long time. So you really need to consider that as a warning to get looked at, go to your doctor, get things checked out, get to an emergency room, in all honesty. Because even though you might feel better, the potential for a bigger problem can be missed if you ignore it. 65% of those are actually within 30 days. So the immediate time frame is important. So what can be done for stroke? Earliest treatment is obviously the key here. So I'm going to talk about treatment in a few slides coming forward. But we want to, as soon as we can, establish blood flow back to that part of the brain so that there isn't any permanent neuron damage, so that the function of our limbs and our speech and our vision is reestablished. We want to limit any permanent tissue damage. We want to preserve our critical, obviously, brain function. We want to prevent disability. I mean, disability from stroke is the biggest, like I said, however $34 billion is spent on caring for disabled patients from stroke. So that's the big factor. Not everybody dies from a stroke. In fact, many patients survive stroke and live with severe impairment. So death does occur, though. So obviously that's clearly what we want to prevent, but disability is also something that is really important to the healthcare providers. So get to the emergency room where you can actually be evaluated by a physician. Okay, emergency room doctors are well educated with stroke. They recognize the signs. They know the information about time. They know what medications to administer. They know who to get in contact with. Even community hospitals like Holland Hospital, we may not have every capability, but we sure have contact with people who do, and they're not far away. And we can get you to the right people at the right time and take care of this. We need to see what your brain looks like. We need to get imaging of your brain. We need to get blood work. We need to check for other possible factors which could be causing your symptoms. Because like I said, not every symptom is stroke, but the concern is what else could be going on. Lab information, and then we have to determine if what we think is happening is a stroke, then we have to decide, are you somebody or is your family member somebody who would be a candidate for the medication called TPA, or the clot buster medication that we use for stroke. So this is a picture of a CAT scan, okay? When you go to an emergency room with symptoms for stroke, the first thing you're going to get is a CAT scan, and you're going to get it quick, within minutes. They're going to get you on a gurney, and they're going to get you down to the CAT scanner. And most patients with stroke will have a normal CAT scan, okay? Most patients, their symptoms are happening so rapidly that there's no opportunity for the CAT scan to change. This CAT scan is actually showing deficits that probably have been going on for hours. Because if you look here, I'll just orient you a little bit and teach you a little bit about CAT scan. So this is the head of an individual. This is sort of the front part of their head, and this is the back of their head laying on the table. So this area here is normal brain. You can see these little gyrus along the surface of the brain. They're well defined. You can see very normal appearing. However, on this side of the brain here, this large section here that looks like swelling, and it's darker in appearance, it's gray, it's got some serious injury going on here, and it's a large portion of the brain. This is a big stroke. This person is going to have major, major problems. This is an MRI. MRI is actually more sensitive than a CAT scan would be in a shorter time frame. So you can have a negative CAT scan result, go to an MRI machine and have a positive MRI that will show an acute stroke, something that's happened within approximately within 30 minutes to an hour. An MRI can be positive, and it can stay positive for up to 2 weeks. So if you have symptoms that happened yesterday and we don't think you're somebody we can use medication on, we can still determine if in fact you've had a stroke, because it will stay positive going forward. In fact, I see patients sometimes come to the clinic and tell me, oh, I had this happen and now I'm weak and I'm not getting better. I'll get an MRI and it's already 7 days past when the symptoms began, and it'll show me that a stroke happened. So MRI is quite sophisticated, a very useful modality for neurologists and clinicians. and sometimes more sensitive than a CAT scan is initially. This is an angiogram, okay? This is actually a picture of the arteries of the brain. What you see here, I'll show you the arrow sign, as we say in medicine. If you see the arrow, that's where your problem is. So in medical school, that was always really helpful. So this is a picture, again, of the middle cerebral artery. It sort of, turns and winds and goes through different bony origins. However, when you get to this point, you can see that there's some blockage. It looks like it gets very narrow, and you can't really see where the rest of it's going. Kind of, sort of, a little bit, but there's some blockage here. If you look here, it's completely occluded in this plane. So there's not, if you look on the left side of the brain, that's actually the right side of the brain, but my left hand is up, you can see here that this is what it should look like, okay? This side, you can see that there's complete absence of these arteries, so this is blocked right here. And again, here it's another picture of where that blood flow has been occluded. So angiogram and CTA or MRA can be used to find out where the blockage has occurred. So when we see something like this in the emergency room, then we start to think, are you a TPA candidate? Should you get this medication to break up the clot that's blocking the artery? So this is given through an IV. It can be given within 3 hours and up to 4.5 hours was a new recommendation within the last several years. I'll get into how this all came about, but it's been on the market since about 1995, and it really has changed the way strokes are managed. But it's actually a pharmacokinetic way of opening these blood vessels and returning blood flow to that damaged part of the brain in hopes that we preserve brain function and prevent disability. So the New England Journal of Medicine is where this came about. There was a very large study, multiple hospitals, multiple medical centers with a large number of patients that were studied given this medication called TPA. Prior to this study, there was really nothing to do for patients, unfortunately, who suffered stroke. It was go to the hospital, find out what happened, why it happened, but in terms of actually saving these patients, it was very limited. So this study, over 3 months, compared patients who were given TPA to patients who were not given TPA. 30% of those who received TPA did profoundly better with less disability in the 3-month landmark or the 3-month mark. So they studied these patients, in their recovery, and after 3 months, these patients who received TPA were 30% better, back to functioning at baseline. Okay. So big change. 30% is a big number in neurology, because compared to 0, it was an incredible leaps and bounds ahead of where we were. It actually changed the standard of care for stroke. So those patients now who have stroke symptoms, almost, if you don't give TPA and there's a reason to give TPA, it's almost like malpractice if you don't do it. It really, it's what we have to do. It's how we save patients' lives. In this study, there was 8 patients that had to be treated to save significant disability. So, in medical research, NNT means number needed to treat. So they treated 8 patients. How do I want to say this? Every 8 patients that they treated basically had improvement. So that's a small number of people. So it really was a landmark study and really changed stroke care. Heart attack care has been improving, and there's been a lot for heart attacks for decades, but stroke really didn't have much to do. So it's really been great. TPA has limitations. Not everybody is a TPA candidate. In fact, there are reasons why we cannot give TPA. There's a long list of reasons why we could not give TPA to an individual. That might include bleeding in the brain. If we do a CAT scan and we see that your type of stroke or your family member's type of stroke is related to bleeding, we cannot give TPA because it would obviously make it worse. Patients who have had recent big, large surgeries or had any other critical bleeding anywhere else in their body, we can't give it if it's been within a short amount of time. So if you just come out of surgery and you've had a large incision and you have a complication, we can't always give TPA because of risk of bleeding. Because TPA is a clot buster, so it can break up clots anywhere in the body. So bleeding risk is obviously something we have to consider, and safety is our utmost concern. There are certain things that we can certainly say, well, maybe we could do it, maybe we couldn't. So there's a list that physicians have to go through and weigh the risk and benefit. The risk of bleeding is obviously the biggest concern, and that's a 6% risk of hemorrhage. Symptomatic hemorrhage, meaning hemorrhage within the brain that would actually cause worsening symptoms and even death. So it's not a small number, but in the grand scheme of things, it's better than the alternative. And most patients and their families are willing to take a 6% chance that it will, save their life over a small chance of bleeding if it's done in the correct scenario. 33% chance for improvement, as I said earlier. So we're kind of getting into a point now in the world of stroke neurology where there's even more that we can do. Endovascular therapy is actually something that's kind of been a new approach. It's been around for several years, but within the last 10 to 12 months, there's been some major changes in the way stroke has been managed. So chemical treatment with TPA is obviously the first priority still, this day and age. Even we always offer TPA, but can we do more than TPA? Because not 30% people get better, 60-something% don't get better, 70% don't get better. So it's still not good enough. So we actually sometimes can give TPA in the artery that's occluded. So usually TPA is given intravenously, but there is a way to give it actually within an artery, and that has to be done by a qualified physician. And they actually sometimes can go into the artery and pull out the clot. So that's been something completely changing for stroke. In 2015, this January, there was a new publication in the New England Journal of Medicine. This was called the Mr. Clean study. This was a very large study that was performed in the Netherlands. And this was looking at patients who had what we call thrombectomy. So this study actually looked at going into the artery that's blocked and actually pulling out the clot, okay? It's done by a qualified neurointerventionalist, so if someone like myself could not do it, I have no interest in doing surgery. But it is extremely complicated, technical, requires good hands from somebody who knows what they're doing, because they're actually doing basically almost like a catheterization. When patients have heart attacks, they get a catheter that goes through the groin up to the heart. They look at the vessels, they can do stents, they can do those sorts of things for the heart. It's the same concept where we can thread a catheter from the groin up to the artery in the brain that's blocked. So, you're going a long way. But when you get to that region where you find the clot, because you see it on the imaging that we've got, and we know where it is, we can go right into that artery and see it, and then we can pull it out, okay? Now that can be done up to 6 to 8 hours after symptoms have started. So you can have received TPA in the emergency room and your symptoms are just not getting better. We have even a little bit more time to get you to a center where they can do this sort of procedure. So we don't do this at Holland Hospital, but Grand Rapids does it. And it's not far away, and we have lots of time to get you there if you come to the emergency room in time. In fact, we do definitely get all the imaging that is needed to identify where the clot is, so we can get you right there, go right to the cath lab, get it done as quickly as possible, because time is still critical. If we can do this in 3.5 hours as opposed to the 8-hour mark, we want to do it as soon as we can, because the longer we wait, the worse chance for outcome. So 13.5% of patients improved over the patients who did not receive this. And in medicine, that's actually felt to be statistically significant. That was a large number of patients. So 32% of patients who got the thrombectomy recovered versus 19% who had just TPA. So even the TPA patients did well. However, they did better with the clot extraction. This is a video of how that happens, okay? So you can see that there's a clot sitting right in this artery. Now they thread a catheter all the way up. They push it through the clot, and this catheter contains a stent, okay? So they put the catheter through, they pull it out, and the stent expands, and it traps it. It's amazing. And then they can pull the catheter back. So you can see here, there's narrowing. That was an angiogram. And so they're going to basically, you can see this is a real life sort of real time picture of the angiogram and the clot, and now they pull it out, and they pull it literally all the way out. It's crazy. So through all these loops and turns and twists. But the stent actually contains the majority of the clot. So that's all it was. It was just a very brief illustration. So this is after the clot was extracted here. So you can see all these blood vessels and arteries here are completely in harmony now. They have blood flow. So this area of the brain, which you can't really see because this is just showing us the arteries, but this region of the brain is now hopefully going to be salvaged or saved. So really, really important. This is a cool picture of a clot that was extracted. So look, that's a big clot. This is the Mercy device. This is similar. This was one of the original stents that was developed. There's probably 3 or 4 now on the market, and I have no idea which device is used. Every hospital has a different device, but it's the same sort of concept. And this is what they pull out. So they're not that big, but these arteries are not that big either. So, I mean, it doesn't take much. So who's at risk for stroke, right? Now you know what a stroke is. Now you know what we can do for it, but who's at risk? So 90% of strokes can be explained by modifiable risk factors that can actually be prevented or changed or improved upon so that you don't develop a stroke. 80% of recurrent strokes, meaning more than one stroke, can actually be prevented if the risk factors are controlled. So when we talk about risk factors, we mean things that put you at risk for a stroke. So there's certain things we can't control. Our age is certainly not something we control. As we age, our risk does go up. As I said in the beginning, that elderly patients over 55 actually do have an increasing risk of stroke. It says for every 10 years over 55, stroke risk doubles for women and men. And in terms of gender, there's also some increased risk. The incidence is actually greater in men than in women, but over the age, I want to say, of 75, I believe women are more likely to die from stroke. So the statistics do vary depending upon age group. Heredity, obviously, if you have a risk in your family of stroke due to, blood clotting disorders or just, bad cholesterol genes or whatnot, I mean, that obviously is not something you can change completely. You can maybe modify it with medications. But race, there is definitely a variation among races. African Americans are twice as likely to die from stroke than Caucasians. Chinese and Japanese, the Asian population also has a very high risk of stroke, even more so than heart disease. And I'm not sure why that is. I'm not exactly sure. I wasn't able to find any information about that. Of course, I didn't really delve into it too deeply. But Hispanics, I actually read some differing opinions about that. It's thought to be a little higher than Caucasians, but again, it varies upon what study you read. So I wasn't incredibly clear about that one. So modifiable risk factors. Hypertension is the number one risk factor for stroke, and it's easily controlled with medication. I say easily, most cases it's manageable. There are certain circumstances where blood pressure can be very resistant, but I mean, we work as hard as we can with the medications that are available. Elevated cholesterol is also something that can be treated. There's a lot of medications now that work really well at reducing levels of cholesterol. Diabetes is a big one. Diabetes is a risk factor for a lot of things, for heart disease, for renal disease, for stroke, for all sorts of other things. So diabetes is a really important one. It's very manageable with medication, with lifestyle changes, with diet, with exercise. So again, something to be mindful of. Tobacco use, of course, everybody in medicine hates tobacco. So tobacco is bad for a lot of reasons, but for vascular risk factors, it's certainly one that needs to go. So alcohol consumption, we'll talk about this. It actually can in some ways can be a little bit helpful, beneficial, and in excess it can be damaging. Physical activity is something you can control. Exercise, getting up, getting outside, walking, exercise. I mean, I don't know, whatever your choice is. If you like to play sports, if you like to go to the gym, just moving. Diet and obesity are the other two things that can be controlled. So for hypertension, for high blood pressure, we do have goals of what we like to keep sort of in mind when treating blood pressure. For patients with hypertension, we like to keep blood pressure under 140/90. That's our goal. Of course, it's not always easy, but we do try with various medications. We at least want to see your systolic blood pressure, or the top number, to come down by about 10 millimeters of mercury from where your normal is. But 140 over 90 is our goal. Now, actually, I say that, but there's a study that just came out not long ago, and I'm not sure how it's going to change medicine, but there was a study that was just done within the last month. It came out, and it showed that patients with a blood pressure of less than 120 over 80 actually did far better than this 140 over 90. So this may even change at some point in the future. So we'll see what happens with that. It's too soon to tell. Patients with diabetes and chronic kidney disease, they actually have a lower goal. We actually want their blood pressure under 130 over 80. And patients without hypertension, we want you 120 over 80. That's normal, actually. So we want you as normal as possible. But if you have a history of hypertension, this is where we'd like to keep you, at least under that number. So for diabetes, we monitor success or progress with diabetes by measuring something called the hemoglobin A1C. So that is a 3-month average of your blood sugars. So you can tell me what your blood sugar is today and yesterday, but I want to know what your hemoglobin A1C is, because that actually tells me what your real control is. So patients tell me, oh yeah, it's good, it was 120 today. I don't care. I want to know what your hemoglobin A1C looks like. If you tell me it's 10, I'm going to say, you can do much better. Actually, 7 was in the literature that I found, but I'll tell you most physicians are shooting for 6.5. It's even gotten more strict. So, cholesterol goals, we look at something called the LDL. So there's several numbers in cholesterol management. The total cholesterol is one number, but the LDL is the bad cholesterol. That's one that we put a lot of emphasis on. A lot of the studies have been done at looking at LDL numbers, and so we've kind of established that a number of less than 70 is what we'd like to see, especially if you've already had a stroke. If you're looking at an individual who's never had a stroke, you might be able to convince me that you could have an 80 or a 90, but I certainly don't want it over 100. But a 70, if you've had a stroke, is where I want your numbers to be. So if I see you in the hospital for stroke, you better believe I'm going to tell your family doctor to get your LDL under 70. So smoking, tobacco, just get rid of it. I can't say anything good about it. It's bad, it's ugly, it's stinky. So you have to quit smoking. Smoking is just a risk factor for a lot of vascular diseases. Alcohol consumption, so this is where we say maybe a little bit's okay, but too much is obviously not good. So for men, they say 2 or few drinks a day is actually could be protective from a neurovascular standpoint. And for women, 1 or fewer drinks a day. Now, you can also read that a glass of wine is good. 1 glass of red wine is actually protective from a heart standpoint, from a brain standpoint. But how much is too much? I mean, obviously, probably anything in excess of this would be considered from a medical standpoint too much. But, we do know that alcohol is damaging too, so you have to keep it in moderation. So, physical activity, they say 30 minutes of moderate intensity activity 3 times per week is what every person should, aim for. There's been lots and lots of studies and literature about exercise, and all across the board it's always beneficial. So I almost never tell my patients not to exercise unless I have a real, strong reason. If you can do any form of exercise, even stroke patients, when they go to rehab, they're getting exercise. I mean, when we send patients to Mary Free Bed after a stroke, you better believe they're working 6 hours a day. Their therapists are getting them up, and they're not laying in bed unless they physically can't get out of bed. I mean, there are severe strokes, obviously. I say this, but I'm implying that you can move, okay? But obviously there are circumstances where that's not possible. But if you can, 30 minutes 3 times a week of moderate intensity. So a brisk walk where you feel like you're a little bit short of breath, like you're having a conversation. You can hold a conversation, but you're huffing and puffing a little bit. So that's where you want to be. Diet, obviously low fat, low sodium. I tell people kind of like the Mediterranean diet is what we are really seeing is something that's, we're following that now for a lot of reasons. I tell my Alzheimer's patients that too. But Mediterraneans, they just live longer. They have healthier lifestyles. They drink wine, they eat fish, they don't eat a lot of fast food, they eat vegetables, olive oils, avocados, things that are good fats. They're active. I mean, the United States, our population, we have a lot of things we could learn from. So the diabetic diet is also something. The DASH diet's another one. So anything that's sort of low fat, low sodium, kind of good fats, not a lot of red meats, things like that are high in bad fats, and that's sort of where you want to kind of maintain your diet. Obesity, if you're overweight, you want to shoot for a goal BMI of around 18 to 25. So. And the BMI is kind of, sometimes it's not always accurate, but that's a pretty good range that you should be within If you're over that, you probably have some work to do. So AFib, I can't talk about stroke and not talk about AFib. I'm going to shift courses here a little bit. AFib is a heart condition, okay? It's basically, the description is that it's when the heart is beating irregularly. So when you think about the heart, it has very steady, normal contractions. It's very effective, very efficient at pumping blood out of the heart to the brain. When you develop AFib, all of a sudden your heart kind of quivers almost. It's like it doesn't effectively pump the blood appropriately out of the heart. And what happens is when the blood is not effectively leaving the heart, it clots. Okay, when blood sits in one place too long, it can clot. That's what our body has that capacity to do that. But what happens is when you form a clot in the heart, one of those contractions could potentially effectively push the blood out of the heart, including that clot, and that clot can travel up to the brain. Okay, that's what stroke happens in a large percentage of patients from that mechanism. So it's certainly, sometimes they're just very small clots, sometimes they're large clots. But it's called a thrombus when it leaves the heart and travels out of the heart. That's the term for it. And it can go anywhere, but the brain is obviously what's the purpose of this talk. So, but obviously it can block the artery and lead to stroke, which is the purpose of today's talk. 10% of patients over 80 years old have AFib. So it's actually a large number of people. And many patients are not even aware that they have AFib. That's the sad part. Not everybody has symptoms. Some people have no chest pain. They don't feel short of breath. They don't feel their heart fluttering. Many people do. Of course, if the heart rate gets too fast and they feel like their heart's beating, then they go to the hospital because they're short of breath or they have chest pain or they're just not feeling right, and then we can find it. That's the good scenario. Unfortunately, some patients have stroke as their first symptom of AFib. And in some circumstances, AFib can occur and then go back to normal. Your heartbeat can actually go back to normal, and when you get to the hospital, it looks like it's normal. We don't see the AFib. So we know that this is a potential for patients, so we look long and hard for it. When we admit you to the hospital, one of the things we do is we put you on a telemetry monitor. So we actually hook wires onto your chest wall so we can watch the beating of your heart, and we can see the manner that it's round the clock occurring. We even send patients home with these monitors for upwards of a month. We now have an ability to implant a little device under the skin to watch your heart permanently if we think you have AFib or you have a risk for having stroke. So, but half of cardioembolic strokes are from AFib. So we know this. We're really aggressive about trying to identify it. These are the patients who have AFib and stroke from AFib generally have a worse outcome. They have worse stroke because they have larger blood vessels that are generally blocked. So it does have some utility in looking for this. When we identify patients with AFib, there's certain criteria that we have to consider, because if we see that your heart is beating irregularly and there's potential for clot formation, we want to stop it. We can't always necessarily reverse AFib. There are procedures and medications to control it. However, we certainly have to consider the potential for that this could lead to stroke. So there's something called a CHAD score. A CHAD score is actually basically identifies all of your risk factors, including age, hypertension, history of prior stroke, history of diabetes, history of congestive heart failure, your sex, and we give you a score. And if your score exceeds number 2, you should be on a blood thinner, okay, not aspirin. I didn't really touch on that much here. Aspirin and Plavix are the main treatments for stroke in certain circumstances, but when we identify AFib, then we're talking about blood thinners, things like Coumadin. Now there's these new medications called the novel anticoagulants. They're different from Coumadin, but they thin the blood like Coumadin does, in the sense that they're different from aspirin and Plavix. And these medications are certainly, there's risks with taking medications that thin your blood. So we have to consider this, but obviously we want to prevent stroke. So when we think it's appropriate, we usually recommend blood thinners for patients who have the score of 2 or greater with AFib. And then carotid artery stenosis is the last point that I'm going to talk about in terms of risk for stroke. So when we admit you to the hospital, if you have stroke or TIA symptoms, we usually will do a carotid ultrasound study. So we'll actually do an ultrasound and look at the arteries coming up the neck, as far up as we can see, because the artery generally kind of splits and then goes off into the brain. But we can see pretty far up where there could potentially be either a clot sitting or cholesterol that has built up and caused narrowing of the artery. So in these patients, we're always looking at this as a potential source for stroke. So 15% of patients with ischemic stroke actually do have narrowing in their arteries. So generally speaking, if we can see that there's narrowing in one of the arteries, then we have to characterize how much narrowing. If it exceeds 70%, then we're talking about, do we need to do something about it? If it's around 50%, we might be able to watch it and get you on the right medications to prevent it from getting worse. In fact, we can see sometimes that it improves, actually. So medications have actually come a long way, and medical management for stroke has become the mainstay. So we can't always change what happens with stroke, but we certainly don't want you to have another one. And so secondary stroke prevention is a big focus of neurology and stroke neurology. So if there are, as I said, if we identify that you have narrowing of your artery 70% or greater, then we have the consideration of what to do about it. So there's a procedure called carotid endarterectomy, which is where they actually go in surgically and open the artery and clean out the plaque, literally scrape it out, close up the artery, and then you're good to go. They also have the potential to do a stent in the artery where they actually go, it's non-invasive, it's, well, minimally invasive, I should say, and they go up and they put a stent and open the blockage. So that's another potential treatment, and in terms of determining who's a candidate for either or, I leave that up to the vascular surgeons. There are criteria for that as well, so there's been lots of studies on this, and it's generally the standard. If we see that you have enough narrowing in the artery to warrant such treatment, it's usually recommended that that be performed unless there's a contraindication. So, I mean, when I see patients, I always listen to the carotid arteries. Just any patient that comes to my office, just for whatever, I always listen to the carotid arteries. Family doctors a lot of times will listen to the carotid arteries as well, just in a general physical, just to hear if they can, because sometimes you can actually hear the blockage. It sounds like a whoosh, whoosh, whoosh. It doesn't sound clear. So sometimes you can actually auscultate it with the stethoscope. If we hear something like that, then we get a carotid ultrasound, okay? In terms of family doctor practices, I'm not sure if it's technically always recommended to just do general carotid artery screening, but I do know that when they hear something, that's when they generally will check. If you have TIA symptoms, meaning you have warning symptoms for stroke, we check it. I mean, if you have any symptoms that sound neurological that could potentially suggest that you've had a TIA or a stroke, we check it. In terms of general monitoring, just for routine physical, I don't know that they do that like they do stress tests and this sort of thing. So that would have to be something you probably would have to ask about if you were, concerned, or if they were concerned enough. Now, if your cholesterol levels are through the roof, they may do it just to check, because there are certain arteries that are more likely to become blocked or become narrowed, and the carotid arteries are one of them. So I just want to summarize, and then we'll have some time for questions. So obviously recognizing the symptoms, thinking of the acronym FAST, so looking at the face, movement of the face, the arm stretch, so put your arms out in front of you, see if one of them is droopy, speech, talking, any symptoms that sound neurological, obviously numbness, tingling, can't walk, dizziness, nausea, headache, any of that stuff that's severe and lasting for a prolonged period of time. Think stroke, and you have to get to the emergency room. There's just no way to get around it. Time is critical. I mean, you really, if you wait too long, we're going to possibly have to tell you there's nothing we can do for it. So we don't like to have to do that. So obviously understanding and doing something about it is the point of today's lecture. Working with your family doctor about getting these things like high blood pressure under control, quitting smoking, losing weight, getting exercise, keeping the cholesterol levels, in a manageable range. Medications are available. Nobody likes to take medications, but I'll tell you, it sure beats being in a rehab facility trying to recover from a stroke. So anyone who's ever had a stroke will tell you that. So questions. I'm sure we have lots. So the question is to sort of clarify the blood-brain barrier and how blood is actually toxic to the brain. And okay, so the blood-brain barrier is a term that refers to the passage of blood vessels going through the brain, but the blood never actually touches the neurons. Okay, the vessels, the vasculature, the elements within the blood that are critical for brain function actually diffuse. So they don't actually, the oxygen actually travels across, but the actual contents of the blood doesn't. It's the oxygen that's traveling across the membrane of the artery. So the oxygen is not toxic, and it's carried along through the blood by hemoglobin, but then when it gets down to the very small microcapillary level, the oxygen diffuses into the cells. So the actual content of the blood is not And then when the oxygen is carried out of the blood, when it goes back to the heart, then it doesn't have as much oxygen. So that's when you're talking about arterial and venous. So the blood-brain barrier is that separation between the artery and the brain tissue. Sure. So with MS, so he's asking about the difference between stroke and MS a little bit. So that's a loaded question. So MS is not a problem with blood flow, though. With stroke, we're talking about a lack of blood flow. With MS, we're talking about an immune response, so an autoimmune problem where the cells of our immune system cross and attack the brain cells. So it's a completely separate pathological process. But symptomatically, sometimes the symptoms can look like stroke. But the time frame of which the symptoms occur is usually much different. So patients with MS symptoms, their symptoms may come on over a few days, but we're talking about minutes here with stroke. Right. So, well, yeah, right. Actually, yes. So most of the population is right-handed. A small percentage is left-handed, but the majority of patients who are right-handed have a left brain dominance, okay? And in fact, a majority of left-handed patients also are left brain dominant. So the left side of the brain actually controls the motor side, the movement of the right side of the body, but also the speech, okay? So our ability to communicate, our ability to understand, our ability to follow commands and this kind of thing is located on the left side of the brain. The right side of the brain does not have as much of that. Some individuals, a very small percentage of individuals, that will be located on the right side of the brain. But the vast majority, it's the left side. So patients who have a left-sided MCA stroke, which controls the speech and the language as well as the motor function of the right side of the body, they will have profound impairments. Now, I've definitely seen patients with a stroke on the right side of the brain, like your mother, who have had very serious impairments, especially if their language center just happens to be located on that side of the brain. But the right side of the brain also controls our spatial abilities, sometimes recognizing even the right side of the body is impaired, and so it can involve a completely different set of symptoms, but still can be quite severe. What was I saying about the left-handed people? I was just saying that so the vast majority of people in the population are right-handed. And most of those people, almost all of them, have the language center of their brain is located on the left, okay? Now, even left-handed people, there's not as many left-handed people. Even most of those people, their language center is located on the left side of the brain, and a small percentage of left-handed people will have language on the right side of their brain. If you're alone and you recognize your symptoms, call 911. Yes. Call 911 and I don't know. Somebody maybe will come to you if they realize that something's happened and you've called, and I don't know. I encourage patients who live alone, actually, who have medical conditions, to have a lifeline. And I tell patients who come to my clinic for other reasons that if you live alone and you have health conditions and you're concerned that if in an emergency there would be nobody to come to you, you should have a button that you can push in case of emergency. And those are available. Because you're very correct. There are certainly, and I've seen a lot of patients where a stroke happened, 12 hours ago, and a family member comes over and finds their loved one laying on the floor in the kitchen or something because they couldn't get up, and because they're so weak. So it's a horrible scenario, but I've seen it more than once. So the question is, how long before a stroke is reported to the state?
Yes. If I've had a stroke.
Oh, for driving? How long before the stroke is reported to the state? That's a good question because...
No, actually, 6 months.
6 months. So that's a good question because I don't generally call the Secretary of State for anything like that. I mean, I don't know who does. Obviously, they sometimes find out because people come to my office and they want me to fill out paperwork saying that they can get their driving license back. So that's a good question. I really am not sure what the time frame is that it's reported or who reports it. Maybe family doctors report it, maybe the emergency room does, but when I see patients in consultation and I see them in my office, I'm not filling out forms or calling the Secretary of State. I do have a conversation with all of my patients whether I think it's safe or not safe for them to drive. And in neurology, that applies to multiple conditions, health conditions. Good question. The question was about anti-seizure medications after stroke. We actually don't start people on seizure medications after stroke unless they have a seizure. So when they do have a seizure after a stroke, which is a fair number of patients, although it's not the majority. But those patients, we do start anticonvulsant medications immediately because after a stroke, we know that there is risk for seizure. So when it happens, then we treat, but we don't prophylactically treat. That's a good question. It may have been in her temporal lobe, which is where sort of memories and that sort of thing. Frontal lobe can have personality changes. So it's sort of hard to answer that question without knowing more information. But the temporal lobes is where our memories is formed, and our speech is also located in the...
Something that's usually a permanent thing.
If it was hemorrhagic, yeah. Yeah. Some patients recover some degrees of their lost function, but the overall regainment of function is sort of determined based on the progress over the first few months, usually. Years out, I mean, if we're talking 5 years ago, the prognosis is smaller. So as time goes on, if the function isn't recovering, I mean, it's less and less of a chance. Of course, it's never zero, but that's a hard question to answer. So blood clots in the leg are a little bit different. Blood clots in the leg after a procedure, so after surgery, there are risks for blood clots based on the fact that you're not mobile, you're not moving. So that's why with surgery, a lot of times we try to get patients moving as soon as possible to prevent stagnation of blood. Now, there are also conditions which predispose one to a blood clotting disorder, like a blood clotting disorder, which can put you at risk for clots in the limbs. Now, does that put you at risk for stroke? Absolutely. But the circumstances of your clot and what tests were done to determine what your risk is how you would answer that question for you as an individual. Because there's a lot of considerations when we're working something like that up from a medical standpoint. So if they identified that you have a blood clotting disorder that would require you to be treated with blood thinners, then that could certainly put you at risk for a stroke. Now, blood clot in the limb doesn't necessarily mean that that's going to travel up to your brain, because that's a long way to go and it has to go through the lungs. That generally, unless there's a hole in your heart, it's not going to happen. But that doesn't mean that if your blood is, at risk for clotting for other reasons, that you could have a stroke. Yes. So I can't give you a direct answer right now because I don't know what your history is. Oh, you had to ask me that one, huh? So atypical, the question is about atypical migraine. So migraine with aura specifically does have risk for stroke in the literature. The percentage I can't give you, it's small. Atypical migraines means that it's a symptom of a migraine, however, it's usually preceded by symptoms that look like stroke. So this is more usually in generally speaking, younger individuals who have migraines. Older patients can have migraines as well. But if your symptoms, sound like a stroke, followed by a headache, most of the time we're going to consider stroke and look into it. Most of the time, however, your MRI is going to be negative, so not a stroke. So that's generally how that's determined. So, and migraines have features that are usually helpful to determine whether one's headache is related to a stroke or a migraine. So, thank you very much.